when she presented to us, they were not sick. So she was managed at the local hospital for this fever as well as rash. And they had managed as possible post-infectious reaction. And she was started with oral coamsclab, antipyretics as well as antihistamines. And she had taken antipyretics previously as well during those 2 weeks of fever. So this was the rash. So as you can see, there are some plaque-like lesions and some blister-like lesions as well. Sorry about the poor quality. These are taken from the patient's own phone. Um, but the oral mucosa was also significantly involved, although not seen when we were looking at her later. This skin rash did not settle despite the settling of the fever. So a dermatology referral was done at the local hospital, and the clinical diagnosis of pemphigus vulgaris was made. But since there was some discrepancy since there was not much of an oral mucosal involvement, so they had done a skin biopsy as well. She was discharged 1 week following the biopsy since the rash settled with hypopigmentation. And then 3 weeks following discharge, she admitted to the medical ward as she had developed a rapid onset, increasing exertional dyspnea, which progressed from MMRC grade 2 to grade 4 within about 3 days. So she was breathless at rest when she presented to the medical ward. So there was a slight dry cough that was involved, but there was no real orthopnea, wheezing, or any other recurrence of fever during this time as well to suggest any secondary infections. No hemoptysis as well as no chest pain. No history of any connective tissue disorders such as muscle weakness or pain or joint symptoms, Zika symptoms, anything like that. Then there was no significant malaise or loss of weight with 10 kilogram. There was a significant malaise and loss of weight with 10 kilogram loss of weight over the last 2 months. So here is the timeline. So she had developed fever and then rash, and then in between that time she has taken treatment. The rash settled on its own and fever also settled. But she, after 1 month of the rash appearing, she had gotten exertional dyspnea, which progressed very short period of time, 3 days, and then she once the skin biopsy was evident, considering the febrile illness, the pemphigus foliaceus, and rapid progressive NSIP, only one main differential came us to mind. That was whether it was an idiopathic inflammatory myositis spectrum disorder involving the ILD as well as the rash. So thought of hemopathic dermatomyositis with atypical cutaneous manifestations of pemphigus foliaceus. So while waiting for the myositis and ENA panel subsequent to the positive ANA and rheumatoid factor, we treated her with IV methylprednisolone pulses, 1 gram daily for 3 days, followed by a tapering course of oral prednisolone. And MMF was also started as a steroid-sparing agent subsequently. So in the antibody screen, what we found was there was a ANA positivity, rheumatoid factor positivity as well, and Rho52 were also strongly positive with the PL7 antibody was positive in the myositis panel. So that is suggestive of that is an antisynthetase antibody, which is a myositic specific antibody. So all the others were negative and the malignancy screening was pending. So she responded well to the steroid supplementation, and plaque lesions as well as a respiratory problem completely resolved, and symptoms were completely absent by 1 month review. But the crepitations did not settle. And currently she's on oral steroid tailing off dose with MMF. With the presence of myositis-specific antibody PL7, a diagnosis of PL7 positive antisynthetase syndrome was made. So that is just a rapid recap of this clinical scenario. So today I'm going to talk about antisynthetase syndrome. It's a subtype of idiopathic inflammatory myopathies. So inflammatory myopathies is a spectrum. There are several subtypes, as you can see. So things you are familiar with, so dermatomyositis, polymyositis as visions you might have come across. And there can be overlap syndromes that myositis is part of a rheumatic disease overlap, such as SLE and systemic sclerosis. And then we come to our topic, antisynthetase syndrome. And in addition to that, immune-mediated necrotizing myopathies such as statin-induced myopathies, and then inclusion body myositis. So I'm going to talk today about antisynthetase syndrome and some useful points for you as generalists as well as specialists. So inflammatory myopathies, they are due to the autoantibodies that are directly acting against the muscle and extramuscular inflammation. So there are two distinct types. One is myositis specific and one is myositis associated. So then myositis specific antibodies are only found in each case of myositis, each specific one. So then they are useful in classification, presence usually distinct of a specific phenotype, and it is useful to plan management as well as predict prognosis and to gather the malignancy risk. So that is very important. Myositis-associated antibodies, of course, one or more may be in each case of myositis. So therefore not specific, and therefore the usefulness in management and prognosis is a bit limited. So antisynthetase syndrome is defined by the presence of inflammatory myopathy and or extramuscular manifestations affecting the skin, the lungs, the joints altogether with an IgG antibody directed against the amino acid transfer ribonucleic acid or tRNA synthetase. So the important thing to gather here is the myositis may not always, even though the name is antisynthetase syndrome and it is classified under idiopathic inflammatory myositis or myopathies, the myositis may not always be present. Rather, not even a hint of myositis or muscle involvement might be there. But still, if there is a rapidly progressive interstitial lung disease with some skin involvement and some arthritis, you definitely have to suspect an antisynthetase syndrome. And they will definitely have a muscle-specific antibody positivity. Very rarely, without positivity, they can present, but usually in about 99% of the time, they have a myositis-specific antibody positivity. So I won't bother you with a bit of detail, but then history, it was found in 1990. And what they found out was they were looking at dermatomyositis, polymyositis, and then found that antisynthetase, this kind of antibodies were positive in those patients. And then they found out that this is associated with a rapidly progressive as well as severe nature of severe ILD. So then that was the main determinant of morbidity and mortality. So they were interested in that. And then it was initially coined for the combination of specific symptoms such as inflammatory myopathy, Raynaud's, interstitial lung disease, and the characteristic findings of mechanics hands, which I will show you next. With subsequent research, now it is classified under idiopathic inflammatory myopathies, and sometimes it does not show all the classical features and depends on what type of muscle-specific antibody there is. So this is how the classification came up. So Bohan and Peter classification, you might be knowing of the idiopathic inflammatory myositis. And then since that time, it has progressed. And now it has come to Solomon's diagnostic criteria, which was established in 2011. And then now we are looking at antibody-specific or antibody-based kind of classification, which is now up and coming. So regarding the epidemiology, it's rare. Age of onset is about, it's very variable, 19 to 82 years. Mean age is about the middle age, 50 years like. Female to male ratio is still prevalent as in other autoimmune diseases, 3 to 1. Prevalence is a bit like 1 in 25,000 to 33,000 worldwide. And roughly 1/4 of all patients with idiopathic inflammatory myositis have the Antisynthetase syndrome. It is associated with several HLA subclasses as well. So pathophysiology-wise, simply put, there is an environmental trigger in the background of a genetic predisposition, and then that stimulates the MHC1 upregulation and release of Jo1 as well. And then there is a complex interplay of T cells, T-cell mediated immunity involving the adaptive as well as the innate immunity, where there is a cytokine release, and this T-cell activity gives rise to antigen presentation, T-cell activation, and then subsequently Jo1 antibodies as well as other antibody synthesis, and this gives rise to a myotoxicity as well as extracellular, extramuscular manifestations as well. Clinical features, of course, you can have fever like in outpatient. You can have myositis. It's usually gradual onset within about few weeks, proximal, and sometimes the esophagus, diaphragm as well as they can go into rhabdomyolysis as well. But rhabdomyolysis is, of course, rare in antisynthetase syndrome. Inflammatory polyarthritis can be there, and then it can actually mimic the rheumatoid arthritis because in about 40% of these patients, rheumatoid factor is positive, as in our patient. And if we did CCP as well, that would also be positive in about 28% of the cases. They significantly come with cough and shortness of breath, and it can be particularly rapid in onset, and it can be seen in about 40 to 60% of the onset of antisynthetase syndrome. And the most common pattern is NSIP or organizing pneumonia kind of pattern, and it can be a combination as well. They can, other than that, as cutaneous manifestations, they can have mechanics hands and hiker's feet, which are cracked thin skin on the palms or the feet, and mainly seen in the radial surfaces of the digits in the hands. They can have Raynaud's phenomena as well as certain other rashes as well, like in our patient where pemphigus foliaceus was seen. So I got you several pictures of a Caucasian patient because otherwise it would not be that evident in our dark skin. So then you can see that there are characteristic Gaustrans papules in this one. So that can also be there in antisynthetase syndrome. There can be a significant degree of overlap in the dermatomyositis as well as antisynthetase syndrome cutaneous manifestations as well. But if you can direct your attention to the E, so there is the mechanics hand. So it is seen in the radial side, and there is like cracked nature, and then it's thin skinned, and they can have periangle changes as well, and they can have the Gottran's papules, ulcers, and other characteristic features of dermatomyositis like cutaneous features as well. Less commonly, they can also have cutaneous vasculitis, calcinosis cutis, periangle telangiectasia like you saw there. Sclerodactyly, they can have a glomerular nephritis as well, and they can develop pulmonary hypertension, either primary or either secondary to the ILD as well. And rare subsection can present with cardiomyopathy, pericarditis, as well as a pericardial effusion as well. So as generalists, that might be of importance particularly. So when regarding the investigations, the muscle markers usually are elevated if there's a myositis. So then AST, ALT will be elevated with a ratio AST more than ALT. Serum aldolase can be elevated. CPK usually is elevated if there's a muscle involvement, but not necessary to diagnose and can be absent as well. So it is the most sensitive of the muscle damage, but important to note is the level of the CPK rise does not correlate with the disease severity. So then you can't get much of an idea from the level of the CPK. But the positivity is important. And muscle biopsy usually shows typical features of fiber necrosis, regeneration, and inflammatory infiltrate, and can show perifascicular necrosis as well. The EMG will show typical myopathy or myositis features with spontaneous increased activity, fibrillation potentials, early equipment, and shorter motor potentials, and low amplitude as well. So when it comes to imaging, so to check the muscle, you can do ultrasound scan as well as MRI if it is available. So ultrasound scan will show some muscle edema and a heterogeneous appearance, but it is very operator dependent, as you all know, and expert based. So then if you go into an MRI, you will see muscle edema, inflammation, fibrosis, and sometimes if it is chronic calcifications as well. The HRCT usually shows the ground glass opacification features with peribronchial lesions as well, and reticulations can also be seen, usually NSIP or OP or mixed, like I described earlier. Lung function test would show restriction. So this is a before and after picture of the ILD, not of our patient, but when I took from literature. So you can see the ground glass opacifications as well as traction bronchiectasis, where the bronchiectasis had persisted, but then the ground glass opacification had settled. So when considering the muscle-associated antibodies, these are associated ones, non-specific. So ANA can be positive. Rho52 can be significantly positive. So almost 50% of antisynthetase patients have Rho52 positivity, and it is associated with a severe lung fibrosis. And rheumatoid factor can also be positive. Other than that, PMSCL, COO, and U1RMP can also be positive. So this is a breakdown of the antisynthetase specific antibodies, where you can see the Jo1 is the commonest. And then other than that, PL7 and PL12 are associated with infrequent muscle involvement, but severe arthritis as well as severe lung involvement. So that is very important to note, as in our patient. So PL7, our patient had PL7, so there is infrequent muscle involvement like our patient, and severe arthritis, somewhat of an arthritis, but then mainly the ILD was the prominent one. And other than that, there were some minor things as well. So you can see that in the anti-Jo1 antisynthetase, the myositis is predominant, but in the PL7 and PL12, the ILD is predominant. So even without myositis, even without arthritis, they can present. And then what is different is the commonest is Jo1, and serum levels, interesting, the serum levels of Jo1 correlates with disease activity. So that can be taken as a disease marker, and it predicts the prognosis and treatment response. The PL12 has the highest frequency of ILD and severity, and it is seen in about 90 to 100% of those, and can be isolated without the muscle involvement. So screening is necessary. So if you get so for the respiratory pulmonologists out there, so if you get a idiopathic ILD with severe features and rapidly progressive, you definitely have to screen for PL12 if possible. And you can have GA manifestation as well. PL7, again, almost the same as PL12. And it can be presenting with a pericardial effusion and pericardial involvement as well. So regarding the classification criteria, earlier there was old one was Bohan and Peter, and now there is an EULA and ACR criteria for the idiopathic inflammatory myopathies. I won't go into detail because the problem is it is not much of a use in diagnosing the highly specialized subtypes of antisynthetase syndrome and inclusion body myositis, because it was actually designed more towards a Jo1 positive kind of antisynthetase syndrome, and therefore it might come as negative in the new criteria. So these are a bit of things. So you consider the age, the muscle weakness, and what kind of muscles are there are involved, and the skin manifestation, the typical dermatomyositis type skin manifestations, like Gottrans. And then laboratory measurements, they mainly consider Jo1 and not the other ones. So then that might lead to negativity or false negativity if you consider our case. And muscle biopsy features as well, including the infiltration, perimycin or perivascular infiltration, perivascular atrophy, and rim vacuoles you see in either inclusion body myositis, dermatomyositis, and polymyositis. So the latest criteria that you can use to effectively diagnose antisynthetase syndromes particularly is what you take is, so there are two classifications. So there's Connors et al. And Solomon et al. So Solomon is the one most used nowadays. So what is required is the presence of anti-amino acid tRNA synthetase antibody, like I described earlier, either Jo1 or PL7, PL12, so on and so forth, and plus two major or one major or two minor criteria combination. So the major criteria are interstitial lung disease, not attributable to another cause. You have to exclude that. And then polymyositis or dermatomyositis as diagnosed by Bohan and Peter. So, and the minor criteria, arthritis, Raynaud's, and mechanics hands. So you can note that in our patient, only the one major criteria were there. So this is not a foolproof one, but it's about 90, what they have found out is 85 to 90% sensitive. And Bohan and Peter criteria, you can see on the left side, it is also mainly the same thing: fever, ILD, arthritis, Raynaud's, and mechanics hands. So, and then these are the major antibodies. And the one more important thing is the absence of antisynthetase antibodies also does not preclude the presence of antisynthetase syndrome. So even if it is negative, you have to consider why, because things like JO1 are activity dependent. So if you had treated previously without knowing for either with steroids or any other immunosuppressants, it might become negative as well, JO1. So then the absence cannot definitively say that it is not there in some cases. So coming into the management, the mainstay of management is glucocorticoids. So you can pulse if it is rapid progressive ILD, and ILD might recur when tapering off the methylprednisolone. So then IV methylprednisolone 1 gram daily for 3 days, and then you can taper accordingly to 1 milligram per kg per day. And then there were many studies done in the antisynthetase syndrome regarding glucocorticoid sparing agents, but there was no real definitive study trial saying one is better than the other. So most studied are MMF, and it is tested in idiopathic inflammatory myositis associated ILD and was associated with an improved lung function with FVC and FVC ratios. And you can use it 500 milligram BD as a starting dose and then go for 2 to 3 grams per day. Then azathioprine, it is the most commonly used in idiopathic inflammatory myositis associated ILD and subsequently antisynthetase syndrome. You can use it 2 to 3 milligrams per kg per day. Calcineurin inhibitors also have been studied, and it is shown to be effective. Tacrolimus and cyclosporine, more so tacrolimus, but you need the monitoring of the trough doses as well in that case because of renal toxicity. And cyclophosphamide has also been tested. It showed a significantly improved FVC and DLCO levels, but due to the higher side effects, the use has been kind of limited by the physicians onto refractory cases and very severely progressive cases. Rituximab has been proven to be effective, and the risk of PCP pneumonia is higher, and you can use the regular dosing of 1 gram 2 weeks apart for 2 doses and then every 6 months. IVIG again has been used like in idiopathic inflammatory other myositis. You can use for refractory or recurrence or severe active manifestations and rapidly progressive manifestations. Other than that, plasmapheresis, JAK inhibitors, methotrexate, as well as antifibrotics like perfenidone as well as nintedanib have also been used and is currently being studied. Other than these therapeutic modalities, you can use physical therapy as well as bone and gastroprotection since you are using steroids. So these are a summary of the treatment doses and what are the clinical uses, monitoring, and adverse effects. But in interest of time, I will go to the next slide. So monitoring, so periodic assessment of CPK and other muscle markers you can do, but they have not specified in any guidelines or any consensus guidelines, but what frequency to use. CPK, other thing is you do not treat the CPK level because it may never come to a baseline in a subgroup of patients according to the research. So then you do not go by the CPK alone, you go by CPK, the clinical manifestations, as well as other inflammatory markers like ESR, CRP, AST, ALT, aldolase, those kind of markers. You get a comprehensive thing. You don't go by the CPK itself because it may not come to the baseline even if the disease is indolent. And other than that, you have to monitor for malignancy, especially skin cancer and lymphoma. You can monitor and give prophylaxis, you should, for PCP pneumonia, especially if they are on steroid and another immunosuppressant. And you can do vaccination as well. Complications, of course, in ILD patients, they can develop pulmonary hypertension. It was found to be in about 7.9% of the patients in a recent study in 2013. And pulmonary hypertension was associated with less survival. And malignancy, the association with malignancy in dermatomyositis is very high. But here there is little evidence. The first case of antisynthetase with a malignancy was only reported in 2008. And what they found is it is only about 1.3% of malignancy risk 3 years after diagnosis. So that was not showing any much change from the regular population. The prognosis, of course, due to the delay in diagnosis is a bit poor. And especially if there is non-JO1 cases, non-JO1 antisynthetase syndrome have a poorer prognosis. And predominant morbidity and mortality are due to the progressive lung involvement, not the muscle involvement in these cases. Disease course is chronic and waxing and waning. Lung biopsy may benefit to prognosticate, although it is not routinely performed. And liaising with respiratory physicians as well as general physicians is very important, as well as dermatologists is very important in view of multidisciplinary management. The poor prognostic indicators are old age at onset, if more than 60 years, presence of any malignancy, negative ANA, and higher levels of Jo1 antibody as it correlates with disease activity. So to sum up, the take-home messages are: antisynthetase syndrome is a component of idiopathic inflammatory myopathy spectrum. It is difficult to diagnose without the characteristic skin changes as well as the characteristic muscle changes, which are not always seen. So mechanics hands, hiker's feet, even though we say repeatedly, it might not be seen, and it was not seen in our patient as well. High degree of suspicion and screening in idiopathic ILD is needed to confirm. So then the respiratory physicians might go into that. And treatment, usually it is steroid and immunosuppressant responsive, like in our patient, but in several cases, it is refractory. Phenotype is according to the muscle-specific antibody. It will denote the clinical features, the treatment responsiveness, and the prognosis overall. Early recognition and aggressive treatment will prevent significant morbidity and mortality. Combined efforts of rheumatologist, pulmonologist, internal medicine specialist, and dermatologist will be needed for effective and prompt therapy. These are my references. I would like to thank Dr. Monica De Silva, consultant rheumatologist, NHSL, Dr. Harindra Karunatilaka, consultant physician, NHSL, Dr. Ravini D.S. Karunatilaka, consultant respiratory physician, NHSL, and SRs who helped in managing this case, Dr. Tulini as well as Dr. Dilashini, and the patient and family members most of all, because they allowed the use of the photos as well as this case to discuss. Thank you very much.
We have 9 questions.
Yes, sir. So yeah, so if we have especially if there's a rapid progressive ILD, we have to see. And then this patient, like earlier, she came with a fever and a rash, but then she presented with a significant gap of 1 month after that rash had came to the medical ward with this ILD. So then when we might concentrate just on the ILD and think of respiratory infection and vasculitis and so on and so forth. But then it's important to go back to the history, like we found out in our case, and to get whether there was any dermatological manifestation involved. And in this case, actually, it was like we were more thinking, like I described, thinking of a dermatomyositis earlier, because pemphigus foliaceus vulgaris were found in like these kind of atypical, and there can be eczematous rashes as well associated with dermatomyositis and amyopathic variant with an ILD. So that is what actually we were thinking of during the investigation. And this PL7 positivity was actually a happy accident because it did not have this mechanics and hiker's feet, all these typical features, and no muscle involvement as well. So I would suggest that if there were the clinical characteristic skin changes, clinical features, hiker's feet, mechanics and that sort of thing, or if there are skin changes coming with an ILD or a muscle involvement, so in that kind of combination scenario, to go ahead with a myositis panel, because it's expensive, so 70,000 odd. So then we have to be very cautious about when to do it.
Okay, can ILD alone be a picture of antisynthetase syndrome?
Yes, sir, definitely. So there were several subsets of cases. About 20% of the cases, the primary, the first presentation was with the ILD. And then subsequently, they had developed, some patients had developed myositis, some patients had developed these skin manifestations. So then definitely, if there is when we are evaluating an ILD, if there are no opportunistic infections or anything like that, if there are no occupational involvement, if no risk factors, no smoking, nothing. So if it's an idiopathic ILD, definitely we have to screen with a basic autoimmune screen as well as ESR, CRP, inflammatory markers, and then go in if there are any features to see any myositis panel as well.